So,
Okay.
yeah,
okay.
I got it. Okay. So the changing demographics of the hip we have come a long way from the Shalini days, when it was generally a preserve of the elderly with low demand, and there was a poly cup and the metal alloy head. But what generally would happen is that it would eventually get loose. So we have this loosening of the prosthesis, which at that time was erroneously termed as cement disease. It was attributed as a characteristic of cement that the prosthesis became loose. So with that, the cementless hip evolved, hoping that it would bypass the so-called cement problems. However, whatever permutation combination was used, whether it's completely cementless, hybrid in which the stem was cemented or the cup was cemented and the rest was uncemented, the problem still remained same, i.e. the stem and the cup got loose. So eventually the culprit was determined as the particulate debris. The challenge for the hip arthroplasty surgeon and the engineers, technologists who develop it are that there was an increasing demand from the younger and more active patients for some implant to bear nearly 2 million steps a year and last several decades, if not a whole lifetime, was a big challenge indeed for both the surgeon and the patient. So there was the science of tribology, which essentially is the interaction between any two moving surfaces that inevitably, like a simple hinge can be taken as an example. And in this, there would be friction, there will be wear, and there will be lubrication. So this science of tribology, as applied to the hip arthroplasty, produced some remarkable insight. Now, first is the contact area. That is, you may feel or think that the two opposing surfaces, they are absolutely co-opted and conform to each other. That is, there is a maximum apparent contact area. In reality, that is not so, because what we are doing is we're talking at a microscopic level. So there is a hills and valleys, thereby causing the wear. Next comes the lubrication. Remember the hinge. When you lubricate it, the doors, windows, they seem to open and shut kind of noiselessly and easily. The same thing happens with whatever coupling is used in the prosthesis, whether it is ceramic on ceramic, metal on metal, or metal on poly. The wear has certain different characteristics depending on the kind of friction that is produced between two surfaces. So there can be a sliding abrasion, that is one sliding over another. There can be a rolling abrasion. Third body is interposition of something hard like a cement or a bony spicule between the two surfaces. And then there is the scratching. So just as an example, a scratching on a ceramic would produce some kind of dent, whereas on a metal head like cobalt chromium, it will raise the surfaces. So the radiological criteria, or what you can see in a metal and a poly, is a reduced distance between the head and the rim. That is, the head becomes eccentric. Now, this can apply to cemented, uncemented, any kind of coupling, which is cobalt on poly, or metal on metal, or even the coupling which is outside the joint. That is the so-called trunnion joint, on which you put the modular head, whether it is ceramic or the metal. So where this seats, you can have a wear, as it were, extra prosthesis wear, but wear all the same, and the net result would be the same. So let us see how these different things produce the so-called wear rate. The worst culprit seems to be per micron unit per year is cobalt chrome on the conventional poly, and the so-called best comes out the ceramic on ceramic. In between, you have the cross-linked poly, and then there is metal on metal also. So putting in a different way, you have this metal on polyethylene, the worst performer, and ceramic on ceramic is apparently the best performer. The wear, when it happens in different ways. The so-called normal wear is when the wear occurs at the normal so-called superolateral aspect of the prosthesis, where the weight-bearing line is. Or it can be a subluxation wear, that is there is a more of a kind of edge loading. So there is a lot more concentration at a lot less area. So the wear would be accelerated. The third mode, as I have already referred to, is the third body, where that is, there's an interposition of something hard like a bone cement or a bony spicule. And then the one that I referred to was so-called extra bearing surfaces, that is the trunnion hitting either the metal or the poly, and this one, that is the backside wear, metal shell, the poly, and in between. So even though it is not quite the bearing surface, but this causes same wear particles which have reaction by macrophages and giant cells, which in turn set up the degenerative process. Because of the disappointing, or rather less than ideal longevity of conventional poly with metal heads, there was a search for the alternative bearings. So the highly cross-linked poly with metal, or metal on metal, and ceramic on ceramic, all kinds of permutations were tried. There is of course pros and cons to all these. So essentially, you can have either a soft on hard or hard on hard. Soft on hard would be metal on plastic or ceramic on plastic. These are the bearing surfaces. Metal shell is outside. Hard on hard would be when a metal head articulates with the metal shell, ceramic with the ceramic, or metal on metal, as in a large, say, surface replacement. So I think let's take one by one. The metal on metal, the pros are, it has a high congruence. That means those rough microscopic hills and valleys are minimized. Higher congruence means less wear. There is a fluid film lubrication, another point in its favor. And because it's a metal on metal, larger heads are possible, thereby at least giving us a theoretical and possibly to some extent practical advantage of very little dislocating chances of the prosthesis. Unfortunately, the cons of metal on metal are enormous. It's a very, very small sized particulate debris. They are submicron particles. They cross the placenta barrier. And even though the size of the particles may be small, the volume is a lot more. And one of the most notorious complications of metal on metal is the so-called L-wall or the aseptic lymphocyte vasculitis associated lesions. Surface replacement is one example of metal on metal with so-called large head. It can have instead of a tiny stalk, it can have a whole stem. But this is not immune to the same wear and tear, thereby causing the wear problems. And this is the radiological appearance. You can see the soft tissue shadow of a metal on metal and the MRI showing the pseudo tumor, which is actually filled with, if you open this, there's a discolored, blackened and very ill-looking muscle and all the soft tissues around. So there needs to be a big debridement before you can stick anything else in. Any surgeon who has seen this will really be put off by this L-wall. The other thing is the rate of the metal on metal hips in the world. It kind of peaked around later part of 20th century's first decade, that is 2007 and 2008. But then there was a precipitous drop because of all these problems that surfaced, and nowadays it's almost a no-touch, a no-go area. And many registries, including Australian, England, and other registries, have shown a lot more revision compared to the other bearings. Now we take up ceramic on ceramic. What are the pros? It has low surface roughness. Thereby, the friction is really reduced. Less friction means less wear. So hardness translates into less wear. Less wear means there is a less chance of the particles being produced in number and volume and setting up the dreaded reaction. It has so-called high wettability. That is, there is a reasonably good lubrication. The wear debris from ceramic on ceramic causes fibrocytic reaction, very few macrophages, and almost no giant cell. That is, it is almost an inert thing. So on paper, the ceramic on ceramic seems the ideal coupling surface. But there are cons. There is no free lunch. What are the cons? At least initially, there was a lot of complaints from patients which ranged up to 20%. 1 in 5 would complain of audible squeaking. But what was much more important was that the ceramics had an incidence, sometimes an uncomfortably high incidence of fracture. So, also, There is the modular cups are somewhat difficult to assemble. There are no elevated liners to bail you out. There is a third body interposition. I've already said that if anything gets in between the two surfaces, soft or hard, it causes erosion or wear of that the opposing surfaces. Edge loading and stripe wear. This is a peculiarity of the ceramic on ceramic. Squeaking and fracture we have already discussed. So this is how that stripe wear looks. And this is the ceramic on ceramic disaster. That is the ceramic fractures. After it's like just like the china that we take tea in or similar. So those pieces, they need complete synovectomy. They need exchange of the whole liner and shell. It's a devastating problem if and when it happens. So now we come towards the what I think is probably a good compromise is the cross-linked polyethylene. The one thing against the conventional poly was that it produced a lot of wear. Its life was somewhat restricted as compared to other bearings, so it fell into disrepute. So the engineers got around this by so-called cross-linking. That is, they give gamma radiation, and the two strands, they kind of link to each other. You see, these are free strands here, and they link. So there's a cross-linking between the two. What that does is, in effect, it takes the wear to a really low value. So this is the graph plotted for the standard polyethylene. As the time progresses, it's a linear progression upwards. Whereas with the passage of time, the wear of a highly cross-linked poly is, compared to this, extremely low. Thereby, much longer survival, and very important from practical point of view, the polyethylene thickness does not have to be enormous to last a patient a couple of decades. Because of the cross-linking wear characteristics, the wear being much less, one can use a relatively thinner shell, thereby increasing the head size, which in turn would reflect on the dislocation rate. The general dictum is bigger the head, and the less the chance of a dislocation. However, this is just one of the factors. It must not be taken as the sole criteria, because there are many other factors at play. But this definitely is one of the strong endorsements of a highly cross-linked polyethylene use. So compared to the conventional, you can see we have already alluded to the longer survival, because there is less wear, and hopefully that translates into much less reaction. It also, as we have already, so various studies have demonstrated this phenomena of less wear. So what would turn out to be an ideal combination of bearing? Let us see. I think we should not completely discard the metal on polyethylene, because the elderly with relatively low demands and perhaps limited lifespan, because this definitely is less expensive. So it can be at least be considered. However, for active elderly, metal with highly cross-linked poly, I think this is the option I would use the most, because it gives me the advantage of the much less wear of highly cross-linked poly, and it bypasses the problems associated with ceramic, because it articulates with the metal. So in younger, I would say go for ceramic on highly cross-linked poly, but some people would probably argue with this, and I wouldn't dispute that. Ceramic on ceramic, because of its wear characteristics, will be a big favorite if you can discard or obviate the squeaking and the fracture incident. So there are newer horizons like vitamin E polymers. Then there is a thing called PEEK, which is being looked at, polyvinyl alcohol hydrogels, obviously with better lubrication. But all these, like any other innovation, I would wait for a long track record, not only with its good characteristics, but with their long-term survival, and what happens if it is there in the body in vivo for a very long time, what kind of problems may arise. So I would rather not be dazzled. I would rather use something that has been tried and tested. And so I think we were talking about bearing surfaces, and we are back to this slide for demonstrating any kind of movement between any two surfaces would be producing the phenomena of wear, friction, and lubrication. I think I would stop there. Thank you very much.
Yeah, thanks, Dr. Sadhoo. As usual, you have this ability to make complex things sound simple and make it easier for people to understand. And I'm sure all the participants would have benefited from your talk. You can stop sharing and then we'll go to the discussions, all the questions.
Okay, stop share. Okay. Yeah,
perfect. You've become a master now.
I had to let my technical help is run away.
Yeah, that's what I'm saying. That's good. So now you can do it yourself next time. Okay. So questions, Janki?
Yeah, thank you so much, sir. So DNB, please, if you have any question, please ask. In between, sir, I just want to know what was in the history before that the plastic means that the polyethylene is not available. The cross-linked poly was not available. In that time, how it was managed?
The cross-linked poly has evolved in 90s. Before that, Chanley, who pioneered the whole, not just the materials, but the whole the environment of total hip, he had many failures. He used many materials. That is, he rigged up in his laboratory many models in which various things were coupled with each other on the lab shelf and underwent a million movements before he subjected them to technical. I have been to his lab in Wrightington, and that table is still preserved.
Yeah.
So it's a pleasure to, and it's an education. It's a humbling experience to see that the finished byproduct we are enjoying here, and so are millions of people. It actually caused a lot of heartbreaks in the beginning. There was this early failures with something like Teflon or some. There are many materials which Teflon. So there was disastrous failure of that. But Dr. Chanle, he just carried on. He was not dejected, and by he came upon ultra high density molecular weight polyethylene, which became de facto standard for the whole industry and for orthopedic surgeons. It is, as I said, because the from elderly population, the focus shifted to the younger, more demanding people, and these things did not last a lifetime. They needed revisions. So there was obvious questions. Can we do better? Is this a cement disease? That was the first. Is this the cement causing? Nobody looked at a polyethylene problem, the particulate problem, which was the problem. So the focus at that time, unfortunately, went to cement. And this had an advantage that so-called cement-less prostheses were invented. So, but problem still persisted. So then everybody said, no, there is something wrong. And that's when the real culprit got caught. That is the particulate debris.
Yeah, so it was interesting because Chanley started with in humans with Teflon as the GUP side, and before he used it, he actually sort of did a small operation on himself and put a Teflon implant under his skin in the subcutaneous region to see if there was any reaction to it. Okay, so he actually did it on himself to see if there was any reaction to Teflon in the human being. And so there wasn't any reaction, but it just wore off because it was soft, it wore off very quickly. And so although the initial results were good, they failed very quickly. So then we changed to this
ultra high density.
Ultra high density polyethylene. Yeah. And then the new highly cross-linked polyethylene came up more recently and has gradually become more and more popular as the surface for the acetabular side.
So in your talk, sir, you have mentioned that if it is hard on hard, then the chance of wear is less. If it is soft on hard, then the chance of wear is little more. So is that means that if it is a hard, that pore size is less because of that, or how we can understand that?
There are two aspects to this. Number one is the number of particles, and number two is the size of the particles. So when you have metal articulating with metal, the size of those particles is so small. It is actually submicron. It crosses placental barrier. It goes into the brain. This is a big disadvantage of metal on metal. When it started off, it was like the savior. But then this is why I say, don't be dazzled. Wait for the track record.
So why did we go to metal on metal? So if you looked at the initial results of total hip replacements with the Chanley and the Exeter hips, they did well, but all of them failed eventually. While some of the metal on metal hips done by Ring and also by Mukhopadhaya, the ones that failed early, but the ones that lasted just kept going on for a long time. No one looked at metal ions at that time. But nowadays, with the metal on metal, they have quite high levels of metal ions in the body, chromium, nickel, etc. And we're still not sure how much actual harm that causes the body, apart from the worry about teratogenesis, because it can cross the placenta. So those are the issues that you need to look at. So Dr. Sadhoo, what is the reason that the Birmingham hip somehow seems to do better and still is being used as compared to the others like the DePuy Johnson, ASR, which has been sort of totally taken off the market?
Yeah, I think, as I said, apart from the die-hard fans, and I would go with the registries, which I think almost universally
have shown a high revision rate. But some of the Birmingham hip seems to be better than, so it's still being used. So even Andy Murray recently had one. So and he went back to playing competitive tennis. He played, although not at the level that he was playing earlier, but he's actually...
Which in my personal opinion is not a good idea.
I know. I think it's going to fail very soon and he's going to be in trouble again.
So it's not a good idea. These things were not meant for that kind of, I think, for a long time.
Absolutely.
Anyway, but to answer your question, yes, why ASR failed and why the Birmingham, I think it probably to do with the design characteristic. I think the distribution of the load of the Birmingham is probably not more even rather than a so-called edge loading. Maybe that might have been shortly, I mean, briefly, I honestly don't know the exact answer to this, but I think it is probably to do with the design, the criteria. The obvious inference would be it's probably a lot more congruent and a lot less edge loading, causing a lot more wear, etc.
So I think we need questions from some of the DNB students.
Yes.
Dr. Avinash, Narayan, I think you people need to understand this better, so you must ask questions. This is your best opportunity. Okay, so don't feel shy.
So just meanwhile, sir, that for the postgraduate, that Birmingham hip is the surface replacement, metal on metal.
It's not a surface replacement, it's a metal on metal hip replacement.
Yes, but it is sometimes
surface replacement also.
Replacement
you can have a surface replacement version of it and a metal on metal version of it.
Yes.
So the original one that it became very famous for was surface on surface.
Yes.
Surface replacement.
But I myself have used a couple of them. You can have a full metal stem with the large metal head rather than a small stalk into the neck.
Yeah, that's right. So
the results would be the same because the wear would be. And as I said, there are some die-hard surgeons who continue to use it, but I do not know how much legal leg we have to stand on if we use.
If they have a problem, then you
get into trouble. Yeah,
I agree entirely.
So what about ceramic on ceramic, sir? Because you have told that problem of squeaking is the reason for metal on metal. So ceramic on ceramic is still we are using, sir? Or
yes, yes. In fact, it's one of the most popular. And as I showed you in my slides, the wear characteristics are really, really good because the debris is the least of all the couplings. Number one. Number two, the debris that comes out, it causes only fibrocytic reaction. It does not cause the giant cell and the macrophage which gobble up and then cause the degeneration of the tissues with the released enzymes. So it's an excellent choice. The only thing was those two problems initially, at least, because like any other branch of science, this is an evolving. The ceramics of 30 years ago are no longer used now. So they are trying to take all the bad advantages, the bad points of it away, and the squeaking incidence has come down. The fracture incidence has come down. There is newer materials like zirconia, alumina, etc., which have coatings, special coatings. So they are extremely popular and with good justification. The only thing is there is no answer to squeaking if it happens.
Yeah, and so I agree with you entirely because I avoid using ceramic on ceramic. Although if you look at it theoretically for the young patient, that's the one that's going to last the longest. So yeah.
And so about the lubrication, sir, because you have told in Tribology that is one part. So when we are using a THR, what is the because in normal joint it is the cartilage, then the fluid, then again the cartilage. That the fluid is the lubricating part. So in the artificial joint, sir, what is that? How the lubrication occurs? Is it fluid is there?
It is the available fluid. I mean, in body, whatever is available will get into the articulating surface. it is how so-called wettable that surface is. As I said, the ceramics is pretty wettable, so its lubrication would be better. Whereas something like metal on poly may not be as lubricated as that, because it would depend on the thickness of the film that is available for lubrication, apart from the fluid itself, synovial fluid, etc. But it's a combination of factors.
Okay, great. Thank you very much, Dr. Sadhoo. I think if there are no other burning questions, we should.
One more question in the chat box, sir.
Oh, finally, okay. Because I didn't think we'll get to that. Yeah.
Yeah.
Okay.
Avinash has
Yeah.
asked
I
that,
think from students,
what-
we need to take the questions.
Yes, sir. What is the difference between ultra high molecular weight poly and highly cross-linked poly?
The polyethylene, which is subjected to radiation, i.e. gamma rays, those individual strands that I showed, they become connected to each other. They cross-link, and there is something called free radicals which are released because of this, which can be harmful. So merely radiating the poly is not giving us the answer. So the process now is to irradiate and then heat it up again, remelt or annealing, which gets rid of most, if not all, of the so-called damaging free radicals and leaves us with a very strongly bonded cross-linked poly. It's a solidified poly, as it were. It's not a very loose, so that it, with the movement and the weight bearing, the wear characteristics are a lot better. This is the reason that with the highly cross-linked poly, the shell thickness does not have to be as thick as with the conventional poly, because of that you can use a larger head, whereas Chanley used only a 22 head. So he had a lot
thicker
of thicker poly available. So that it would wear out in many years.
So highly cross-linked poly is also ultra high molecular weight polyethylene. It's just that you treat it.
It is treated by two different processes.
By processes to make it into highly cross-linked. So it's the same, originally the same.
Yes, the material is the same.
Weight polyethylene that is being used. Okay.
Its material is the same, and the processing is different. Radiation followed by heating, remelding, or annealing.
And they also add vitamin E to it, and those are the things which they are to try and
as I said, even vitamin E can cause some problems. So it's,
yeah, that's right.
So you need to be treading carefully here.
Okay.
Just to mention for the postgraduate, this topic is the most important. I find it because in every year they used to ask the question like zirconia, alumina, even static friction, dynamic friction, and many things they have asked. Tribology. So
Tribology. Okay.
Tribology.
So yes, I think it's important, and that's why I was wanting them to ask more questions. But anyway, thanks a lot, Dr. Sadhoo. That was great, and we'll certainly be delighted if you can join us again in the future. But we need to bring this to a close now. Thank you very much, and bye, everybody. I think this is an important topic, and I think Dr. Sadhoo has really made it very simple to understand. And so you should have gained a lot from this talk today. Thank you very much.
Thank you so much, sir.
Thank you, Janaki. Bye-bye.
Okay.
Thank you, sir. Thank you, sir.
Are we off? Are
Yeah.
we no longer live?
No, we are still live, sir. Just because.
Okay.
Yeah.
All right. Are we through now?
Just a minute, because I'll just.